So we've had to pivot this panel a little bit. Unfortunately, two of our panelists that were in the program couldn't make it this morning. Andrew was voluntold to jump on the panel. And Rick is also kind of graciously accepted to adapt to this new format. And I might throw in some thoughts as well. Andrew has already been introduced. Rick is a scientist at ICS, also the director of ISPR at CIHR. Rick, can you help me with the ISPR acronym? Institute for Health Services and Policy. Yeah, I should know that, but yes, at CIHR, and also has done a tremendous amount of work, as we've heard. I think Jane mentioned some of the reports that Rick wrote earlier, a tremendous amount of work in primary care. So we wanted to spend a little bit of time in this panel just to think about the crisis, essentially an overview of the crisis, and what are the dangers of doing business as usual? Where are we headed if we don't change what we're doing? So Rick, I don't know if you want to get us started. We've asked the panelists to think about kind of three aspects. One, kind of examples of the impacts. The second being kind of what will happen, what are the future consequences of this crisis? And the third being, what do we think are maybe some of the solutions to this crisis? So Rick, I don't know if you want to get us started with some thoughts, and then we'll move to Andrew.
Sure. Thanks very much. I really appreciate this opportunity to speak with you this morning. I'll provide just a tiny bit more context before I jump into the questions, if that's okay, which is that I'm a family physician. I actually practice in the same center that Andrew does here in downtown Toronto at St. Michael's Hospital Academic Family Health Team. I also co-lead the Inspire PHC program that's ably, with Dr. Mike Green, who's here, and ably coordinated and also led by Elliot Freimeyer, who's here. Tara Kieran is a speaker later this afternoon, and other colleagues like Camilla Premji are here as well from that group. There's an Ontario-wide Ministry of Health funded research network. And I'm a scientist at ICS, where I've had the great fortune to be able to access linked administrative data and to be able to work on all of this. And then colleagues are here from CIHR, from the Canadian Institutes of Health Research, Institute of Health Services and Policy Research. So Dr. Meg McMahon is here in person, Associate Scientific Director, and Dr. Jessica Nadigal is online with us, also Associate Scientific Director. And I will say that, you know, having been preceded by people like Morris Barrer and Colleen Flood and Robin Tamblin, it's just a great honor, privilege, and very humbling to be in this role at CIHR. So should I jump into the, okay. So I'm just going to, with that, jump into a little bit of the problem space. But because earlier presenters, including our fantastic moderator and Jane Philpott, have really said 90% of what's on my notes that I was planning to say, I'm going to focus a lot more on the solution space, and nobody will be surprised if I talk about research and need for evidence in all of this as well. So just to highlight the nature of the problem. So, and we've heard about it already, but consider that Canada now has 40 million people, and that within 3 to 4 years from now, 10 million Canadians will not have any access to primary care. 10 million Canadians, quarter of the population. It's very unevenly distributed, as we've heard. It's unevenly distributed in the East, West, North, South, Indigenous communities, racialized communities, low-income communities, new Canadians, very, very unequal, but still we have 10 million Canadians in the very near future without any source of primary care. And just consider the impact on their health, the health of their families and communities, and the impact on the health system of having that disaster happen in a country that has universal health care. It's kind of unbelievable that this is happening and that we're going to have the most severe consequences. We also don't have a system that anyone wants to work in. We are expanding medical schools, we're expanding nursing schools, we're expanding nurse practitioner and physician assistant training. This year, as it happened last year and for the last few years, there are roughly 100 unfilled family medicine residency spots in this country, funded spots to train family doctors that no one wanted. That's including a second round that included international medical graduates. So even after that second round, we still have close to 100 unfilled training spots. People do not want to work in this area. They do not want to work in this discipline because the working conditions are just not what they want. Recent graduates and our residents and recent graduates in family medicine want to do meaningful work. They want to do things that are meaningful in their community. They want fair reimbursement. They do not want to be paid on fee for service. They want benefits. They would like a pension. They would like to be able to take time off to spend, on a parental leave or with their family. They don't want to struggle to find a locum, which is a replacement physician for their time. And we actually are training them in these beautiful places called academic family health teams in Ontario, and they're called other things across the country, FMGs in Quebec, PCNs in Alberta. We've got these marvelous places, academic homes where we train people and we send them out to hang up a shingle and to rent a space with colleagues and to hire and pay the staff, try to manage their computer systems and electronic medical records, buy all the personal protective equipment when there's a pandemic by themselves and at their own cost. Deal with rent escalations of up to 25 or 30%, staff costs that are going up with inflation 10 or 15%, and have no change in their reimbursement, running these small businesses that we never trained them for, oriented them for, and that they never wanted in the first place. So when I think about, when you think about the system that has been so well described by Jane and by earlier speakers, we've got this really big disconnect. So when we invest, and there are these billions of dollars in federal government money and bilateral agreements that are going into care, they already seem to be going into the same old. They're going into things like physician income, physician reimbursement. I'm the last one to argue against that. But honestly, if we spend more on hospital beds and we spend more on doctors and nurses' salaries go way up, and all those things are important and necessary, but when we don't change the system, we will not get different results. We're going to get exactly the same dysfunctional results that we are getting now. We'll kick the can down the road for 2 or 3 years. Anybody remember the fix for a generation that happened in the early 2000s with Paul Martin? We spent a lot of money on healthcare, and we actually didn't get the results that we needed from that. And so I'm just going to just to say, I think there's a fundamental change that we need to have. And after both of you have had a chance to speak, I'll come back to like that solution space, but I'll just finish the problem space by saying that if we think about what health systems are supposed to accomplish, they're supposed to accomplish 5 aims. It started with the triple aim, then became, quadruple, and now is quintuple. But, we're supposed to improve population health. And we've heard our population health outcomes lag other industrialized countries. We're in the middle of the OECD, and we're at the very bottom with the US of the Commonwealth Fund International Health Policy Survey group of 11 countries. So our health outcomes are not what they need to be for population health. And in primary care, we actually don't take a population health approach. We don't look after all those people who don't have access to care, and we don't have a system to be able to do that. So we're failing on population health, and now these 10 million people are not going to get care. Jane has already said they're going to die. They're not going to get preventive care. They're going to delay care. They're not going to be part of the system. They're going to turn up in emergency departments very late in the course of their illness. They won't get cancer screening. Their blood pressures won't be controlled. They won't get advice about smoking, alcohol, substance use, etc. So that's the population health part. Then there's the provider and patient experiences part. Patients, being these 10 million people being lost in the system, are not going to have a great experience of care. Let's just be clear about that. Those who are in the system, less than half historically on population surveys have been able to access care on the same day or next day. I've had a little peek at the most recent Commonwealth Fund International Health Policy Survey. It's now down to 25%. 25% of Canadians who have a provider can get in to see them in the same day or the next day. And this has plummeted from being in the kind of mid 40s. So this is the kind of latest result that's going to be released soon. And it's just a disaster. So even those who nominally have a provider can't really, it's very, very challenging to get in to see them in a time. So this is the patient experience. The provider experience is in this downward cycle, right? People have more administrative work, more administrative burden. Colleagues are leaving and narrowing their scope, which provides them lots more to do. And people are burning out at a rapid rate and not wanting to be in the system. So we saw this in the late 90s, just coming back to the 1960s. I certainly was around in the late 90s and early 2000s when actually only 23% of medical students were choosing to be family doctors. And we were in the high 30s. We're now down to 30 and falling fast. But we've seen this happen before. So the provider experience is very poor. And as I said, we have this disconnect between training and the work environments that people can go off into. And then when you think about what happens to costs, because this is one of the 5 aims is, sustainability of the system, it is much more expensive to look after people in emergency departments and in the hospital than it is in the community. And people don't want to be looked after in those places. People would like to have, so countries that have strong primary care, as has already been said, quoting Barbara Starfield's work, much greater equity and greater satisfaction at considerably lower cost. And then if you think about, will our system be overwhelmed? Well, our system is overwhelmed. Our system is already severely overwhelmed. We have all these people languishing in hospitals who have nowhere to go, called alternate level of care, which is some euphemism. And then we also have all these people who can't get access to the system. So I'll stop there. The consequences for the system are actually quite severe, and for the health of Canadians, for our budget, if we don't invest properly in a system. And I'm happy to come around in the second part with what I think solutions may be. But I think the consequences are dire for life and limb and pocketbook and all of the things that Canadians care about.
Andrew, do you want your slides, or do you want to just go on the problem?
I'll make a few remarks before, similar to Rick. I'll just add a few thoughts about the consequences before going to kind of some of the solutions. And I think for everybody here too, when we're, again, thinking about these provincial and territorial plans that we're co-developing here, it's keeping an eye on these items and kind of citing them as part of the rationale to do things different, to have a different system. Just to add to some of the few thoughts to what Rick presented, there's some things we haven't touched on as yet. One is that this cycle that we're now very much in, around poor quality leading and lower access, provider burnout, and patients' experience, and that experience that we're all in right now. It's also, one aspect is it's also opening up the opportunities for private and for-profit entities, and they already have a foot in the door. This is really widening that. There's a number of consequences for that. One is, of course, widening disparities, because the people who can afford, who can say, instead of I'm tired of that system, I'm going to go pay and access, get my care quicker, more responsive to me, as Mélanie Ann mentioned, the kind of retail, Walmart kind of, and other companies kind of doing this, it's going to widen disparities, because who can afford that? It's going to be certain sections of the population. Another kind of aspect of that is also data capture. And this is from some of the work that we do at the Upstream Lab. It's also just keeping in mind that this is opening doorways for privatization of data, and also what companies can do with this enormously rich data that tells them so much about consumers. What else could they use that for? Another aspect, a second kind of aspect of this, is we're going to start to lose the middle and higher income groups. We're going to lose them in terms of the support that has been a bedrock for Canadian healthcare as an idea and as a principle, and as something that we accept that, yes, regardless of your income, you have access to healthcare services when you need it, as flawed as it is right now. But we can just start to imagine what that will look like, where people start to say, well, if I'm paying for this, for my primary care on demand when I want it, why should others, we'll start to lose that solidarity. A third kind of aspect, which is related, is the danger of business as usual is we are really not engaging our communities. Communities have this enormous power and enormous ability to demand change, demand access, to have that social solidarity. And we really are slipping behind on that. I'll just end by kind of citing the World Health Organization vision for primary healthcare for the 21st century. It's a really helpful document, and I'm skeptical of sometimes these documents that come out and they sit on a shelf and it's not really sure what they're for, but really encourage you to think about that, because what I see as quite radical with this vision is it does have essential primary care services, which a lot of us, I think, are thinking of when we think about this challenge of access to primary care. It also cites essential public health activities, which is kind of interesting. So it's a three tripod or three-legged stool kind of thing. So you have essential primary care and public health services, all put into one leg of the stool. You have population health management and outcomes, which is also quite neat when we think about primary healthcare, and kind of picks up on what Rick was mentioning about the need to think at a population level. Are we improving population outcomes? Some of you may have seen the news recently that, again, life expectancy in Canada is declining. So that's the second leg of it, is population. And the third is empowered communities. So again, this is a really radical vision. Imagine what this could look like in Canada if we embrace this vision of essential primary care and public health services for all, universal, population health, and empowered communities that mobilize that. So just, I'll end there and turn it back to you.
Yeah, thank you, Andrew. So we've heard it's getting worse, and it's about to get a lot worse. We've heard, people don't want to work in primary care because it's so bad. We've heard the private sector is going to erode the support for universal health care. And we've heard that we're not really empowering our communities and putting in place the WHO vision for primary care. That sounds very dire. I will add a few things just quickly, and then we can go to the solutions. My thesis work was around unattached patients and centralized waiting list. And one of the things that I found was, even when we have a mechanism in place to get people a primary care provider in some way, we are creating inequities. So the people who are living in the most disadvantaged areas, people who are suffering from mental health, are left on these lists for years and years and years. So yes, we will have 10 million unattached patients, but I would argue that that will be a driver not only for lack of access, but for for inequities. It will be the sickest patients who need access to primary care, who are living in disadvantaged areas, who have a bunch of other reasons for getting sick that are linked to the social determinants of health, who will be unattached. So that is something to keep in mind as well. The other thing I would argue is that business as usual is not an option, because we have a climate crisis coming, and it's already here. I'm sure across the country, we have seen in this past year the consequences of fires and floods, both in terms of health, respiratory health, physical health, injuries, but also mental health consequences of this climate crisis. It's not in 10 years and 20 years, it's now. So it's not going to be an option to continue to do what we're doing now, or we will lose primary care altogether. So on that dire note, what are your solutions?
Oh, I'm so glad we're getting to this part. The other parts are just excruciating, aren't they?
Aren't they?
Every good crisis, has some opportunities, right? And I think we're at that moment where things are so bad and getting worse that there are and will be increasingly over time tremendous opportunities to change, because the status quo is untenable. And I think that coming out of today and tomorrow, as Andrew has asked, if we have some ideas or a plan that we can all agree on, not 100% agreement, not an exact plan, but we have an emerging idea of where we're going and what we're doing and what's going to happen. And we engage communities, because when we as health providers and researchers, when we, advocate for certain things, we sometimes come across as, self-interested. Patients and communities are what's going to make this happen, right? An engagement with those folks and an understanding from those folks about where we have to go. And I'm not going to steal too much thunder from Tara, who's going to tell us all about what Canadians want later today. So just in terms of moving into the solution space, so we've currently in primary care got this independent contractor model. And honestly, in most jurisdictions, people don't know who is doing what, where they work, how to contact them. Danielle Martin, who's here, the chair of my department, one of my 7 or 8 bosses in my professional life, led a report, and I was privileged to be a small part of that report that went to the Ontario Science Table as the last set of the 3 last reports. And public health was unable to contact Ontario family physicians because there was no list with contact numbers. Nobody knew who they were. And I'm not advocating to make this list. We should, of course, but it's just emblematic of the fact that we don't have a system. How would you run a hospital not knowing who your employees were or what they were doing or when they were coming in or what hours they worked? How would you run any business or any enterprise not knowing that? So here's the transition. I was fortunate enough to sit on and contribute to a panel called the Baker-Price panel or Baker-Price report of 2015. And we debated for ages about what would ensure 100% full access to primary care. And the thing that we came up with is that it kind of has to be geographic. There has to be something like what Jane was talking about. It doesn't have to be exactly a school district, but there has to be some geographic and community-based responsibility for primary care that is guaranteed. And if you don't have that, I think with this independent contractor model, you will never have anything like full enrollment or full access to primary care. There has to be some local governance, some local responsibility, some community or shared governance kind of model with deep community engagement so you can meet community needs. And it's a pretty radical departure from the independent contractors. The independent contractors are actually really suffering now. They're in an unsustainable business model. And yes, there are people who want to carry on as they were. Our new graduates are not among those people. Our new graduates are going to flock to a model that has these elements in it of meaningful work with alternate payment in an organized system. They don't necessarily have to be employees. There are a whole bunch of different kinds of models that could work, but you need a community-based network of providers that have accountabilities, that have governance, that have appropriate supports, and that of course are teams. So this idea of local geographic responsibility where someone moving to a place will automatically have primary care. Tara may touch on this later. We have a paper coming out on Monday about what are other countries, just this coming Monday, just what are other countries doing in this space and how have they built their systems? We looked at countries that have more than 95% primary care attachment. So again, not stealing too much of Tara's thunder for maybe later. So these are going to be systems that trainees are going to want to work in, that patients are going to love. They're team-based. They've got a whole range of services to provide for them. We need new roles too. We need community health workers. Andrew Buzari would have talked about that for sure if he was able to be here. He's building a whole system of housing and community health workers and nurse practitioners and outreach and community-based services at Canada's largest tertiary quaternary hospitals here in Toronto, which is kind of an unbelievable thing that's happening. So just imagine for a minute being new to your community. It could be a small town, could be a big city, and you sign up your kids to the school, and you have a very simple process to sign up for the local primary care community center. You have a team, you have a relationship with a provider, that may be a doctor or a nurse or a physician assistant or a nurse practitioner, maybe any one of those, but attached and coordinated with a team. They either speak your language or can get a translator on the line in a very short time that does speak your language. They provide cultural safety for you because you've had some pretty rotten experiences in your life and your family has in healthcare, and you don't necessarily always trust the system. There are after-hours services, evenings and weekends, available to you. These services are comprehensive. You have continuity of care with a provider who you get to know and trust. Your care is coordinated when you need to see a specialist or go to the hospital or get tests. There's appropriate same-day, next-day services when they're needed. Not everybody needs to be seen the same day. You can access your records online, and you can provide that, and all your records are in one place, and you can provide that access to providers that you choose to have. You're connected with community services. If you need housing, food, you need transportation to appointments, you need all kinds of things, you're connected to those services, and there's a whole team of health professionals that are going to look after you. So this sounds impossible, doesn't it? What a pie in the sky. You know, just about every European country has this system. And they spend less on healthcare per person than we do. They spend more public dollars than we do as a proportion, but their overall health spend is less than ours. And I've just described more than half a dozen countries in the world that today, and there are countries in Asia that do this. There are countries in the Middle East that do this. Costa Rica does this. Like, when you look at systems around the world, there are lots of places that do this at much lower cost than we do. And we lack the political will and implementation to do it. So here's my wish. My wish is that we took 1%, I'd accept 0.1%, I'd even accept 0.01% of that $30 billion health transfer that we've been talking about for evaluation, research, evidence, and implementation support. So this is the kind of learning health system kind of concept that we talk about, but we implement things, and we're going to implement solutions to primary care. We are implementing solutions to primary care across the country. Most of them are unevaluated. I've had colleagues in British Columbia tell me they can't, and I hope some colleagues are here from British Columbia. I know there are. I can see that. I can see Bonnie Henry is here, and Sabrina is here, many others. They're having trouble getting policymakers to even sign on to help them evaluate the new primary care funding model there. So we've got, so we need, when we're implementing things, we need to monitor, we need to evaluate, we need to have measurable targets, we need to have timelines. So the 0.01% could go to local support for implementation and implementation support. We have an increasing cadre of embedded researchers. There's at least one health system impact fellow in the room here, maybe two or three. There's now a whole health system impact program led by Meg McMahon, where we have embedded scientists now across the country in hybrid roles between universities and health system organizations. More than 100 health system organizations and 26 universities have hosted health system impact fellows, and there's now an early career track as well. So I'll stop there for the moment, but just to say that we don't implement well. We do these pilot projects. And if we had, as we're doing the implementation of hopefully these bold new models of care, we don't actually know what is the optimal team. We don't know what is the optimal payment model. We don't really know exactly what is the size of the population, minimum, maximum size that should be in a local area that gets local services. We need to discover those things. We need to be curious and open, and we need to have the implementation support to pivot, to change, to achieve the outcomes and targets that we've set for ourselves and work towards those. And that will be different in the north, south, east, west, BC, Alberta, Saskatchewan, Nova Scotia. Many of you are here. You're going to do it differently in your settings, and it's going to be different in different parts of your jurisdictions as well. But those are my wishes. Okay, I have something for later, but I'm going to stop now.
Thank you, Rick. So we have maybe about 5-6 minutes, Andrew, if you want to give us your thoughts on solutions, and then maybe we'll take some time for burning questions. You want to come up here?
Yeah, I'll just come up here. Thank you so much for that, Rick. And I think, again, just to we'll come back to this, but I think everybody here is highly aligned with the vision, which I was just, writing down 6 kind of key things: 100% attachment that's based on geography, team-based care, high quality, including that point about access, integration with health and social care, access to one's own data, and data that's used creating a learning health system approach. So the work of this meeting is really how do we achieve this vision, including both the tackling the obstacles, like Mélanie Ann kind of alluded to earlier, the vested interests that are stopping this, but also building community mobilization to make this happen. So it's not just another report, but it's actually something which policymakers can't ignore. I had just to add to the kind of solutions, I have just a few slides which maybe can be brought up just to add to this point about how do we build upstream systems. Just to add this to the discussion. So this over here. Thanks. So I always like to make this point, just to remember the system of tomorrow hasn't been built, but it's actually the product of our vision. And this is, like Rick noted, we're at such a stage of crisis that there's opportunity for a more clearer utopian vision. Next slide. I'll try to make this work. Oh, okay. So this is a definition of an upstream system, a system that continuously supports improvement of health in the broadest sense, is tied closely to human rights. And this connects a bit to what Suzanne and Ali mentioned too, is this concept of rights as well throughout the life course, through a primary focus of attention and resources on the root causes, while still maintaining the capacity to address acute illness. That has community ownership. And I really would love people to think and to speak about that too. What would that look like? Community ownership and governance, which could be, for example, this school district model, which a few people have talked about. Remember, one of the interesting things with school districts is that we have a school board that's elected officials who are engaged in that governance as well. What would that look like for primary care? That there's direct action on policy change, and that also an upstream system is a catalyst for creative alternatives that kind of spill into other parts of society. So imagine these upstream systems also are a place for that catalyzing those discussions that get into things like education, housing, work, and other kind of key determinants. So 5 building blocks, and then I'll stop, one is evidence on interventions that actually go upstream. The Upstream Lab now is about 8 years old, and we've been doing a lot of work bringing together evidence on multiple levels at the meso kind of micro level of individual to organization to policy level change. Second building block is data that has impact both at the point of care, but also for system evolution and also holding systems accountable, again, tying it back to communities. And this is just a framework of kind of how we can bring these together and kind of making the point that data is really central, including patient-reported and inferred social data as well. And there are many important issues about data, which was noted by Ali and Suzanne as well, about Indigenous data governance and sovereignty, community engagement, transparency, data quality, and so on around this type of data. One just additional framework just to draw your attention to, again, because it can be part of this, is this EGAP framework, which really is how can communities be engaged in the governance of these systems and actually be involved with handling the data. A third building block is actually envisioning these health system evolutions being accelerated with public movements. What would that look like? How do we engage our patients and communities in this type of process? We have a number of patient and community members here, as well as people who are joining online as well. And really, that's going to be a key part of what makes this go from, again, just a nice report for another conference to actually action. And we've done some work also on the connection between health centers and democracy, including things like just plain out voting. Imagine if all of our health systems and centers, particularly in primary care, was so close to communities, actually were engaged in engaging people in democracy, which needs some work with Dan Raza, who's here as well. A fourth building block, which public health has done for many, many years, is communicating to the public about what really matters. to our health. How can we have, I love this work from the Sudbury District Health Unit about how do we have a conversation about health without talking about health care alone? How do we talk about these broader things that make sense? And finally, changing how we educate and train people in a generation. And this is really, really, really important. It also ties to what Suzanne mentioned about the current kind of challenges that are being posed to equity, diversity, and inclusion, and really this important need to change how we train people as well. So just to summarize, these are 5 blocks that I think can help us with that aspect of, while we're doing this, also making it more of an upstream system. Great.
Yeah, thank you, Andrew. So just in the interest of time, we have about 5 or 6 minutes left before Izzy gets angry with me, I think. And then we're running behind schedule. So I'm going to open it up for questions, but we have heard kind of the dire problem that we're trying to face, and we've heard kind of potential pieces of solutions, including kind of 100% geographic-based attachment teams, access to data and evaluation, some sort of primary care system that's community-owned, and building kind of this upstream idea where we're acting a little bit higher up than what we're doing now, that's kind of more disease-focused, and then focusing as well on education. I will kind of add just one last piece before we get to questions, which is kind of what I've been working on with some people in the room, with Maxine and Mélanie, who are here in Quebec. And it's also just thinking about the fact that a lot of people have solved these problems already, kind of at a local level somewhere in Canada. And we're not learning from it because we're not spreading and scaling. And it's sort of this idea of creating an innovation amplifier in primary care, so that we're actually kind of testing things on a local scale. We're learning from it, but then we can amplify it, and we can build these trajectories for spread and scale kind of more easily, and what that looks like with policy levers and funding. So that's just one idea. Yes, there's a question here and then a question there.
Can you all hear me? Thank you. I'm not a clinician, I'm a public economist. One thing that has struck me this morning from what I've heard is 10 million Canadians might be without health care. And maybe I heard somewhere and they could just die or be less productive. So just pointing out, there's a tax angle to it which could pay for the health care. The average wage earner in Ontario earns $55,000 and pays average taxes of $9,084. That's about $100 billion a year that could be lost in tax revenues. If only 25% died, then we have less taxpayers. All patients are most of them are also by definition taxpayers. Mm-hmm. And we can't forget that if we just broaden our zoom lens, we might be easily, or not easily, but be able to justify why we should provide them healthcare. They're not just taxpayers, but they're also employees. So employers might find it in their interest to take care of their employees, like they do, mental health, because if they're 25% more productive, they'll produce 25% more profits for the employer. So whether, sick pay is not something that employers do out of charity. It's in their economic self-interest because that's what aids productivity. So there's that whole angle. I would encourage everyone in the room to look at it. It might just justify a few things. Thanks.
Thank you.
I'll just respond very briefly, if that's okay.
Yeah, go ahead.
Audrey Laporte, I don't know if she's here right now, but she's coming tomorrow, reminded me recently in discussions about how do we measure return on investment in primary care, because this is really key for policymakers, that there are 2 really big buckets of costs. One is saved costs in the rest of the healthcare system, where the hospitals, emergency departments, all of that. The other, I'm just picking up on this comment, which was excellent, is the health of Canadians. And how do we cost the gap? And Sterling, maybe we can talk about this later too. There's more than one health economist here. So just talking about, the change in the health of Canadians has got enormous cost for employment, caregiving, going to school, paying taxes, being functional members of society. So, and those costs may dwarf the saved costs in the rest of the healthcare system. So I think we have there's a big research agenda here around roles, teams, all that kind of stuff, governance models, payment models. But I think there's a big agenda, a big research and evidence agenda that our policymakers actually really need about what is the return on investment. Because we're talking about really big investments, but we've got a lot of money coming into the system, and we have a lot of money being used for other things. So that could be very productively used here.
Thank you.
So first, thank you for another excellent panel. At the risk of being on the mic again, I wanted to just add a little bit of context about Denmark and then make my question. So one of the things I think is really important to understand is that in Denmark, higher education is completely free for everybody, which I think makes a much more equitable range of people who are then moving on to higher education. So I think that's an important thing for us to recognize. Also, every physician that trains in Denmark has to train to be a family physician, and they have to do that for a number of years before they are even eligible to practice as a specialist. And even when they go to do that practice as a specialist, they have to maintain a certain percentage of their time as a primary care provider still. So there's some really interesting things about the way they structure that. Their pay is also much more equitable. A family physician in Denmark makes about $3 more than a server at your restaurant. So I think there's some things about Denmark that we would love to emulate, and we would have to get much more equitable in our thinking around that if we were to do that. They also have one card for all of their data, their healthcare data, what books you took out at the library, like everything. They have the most incredible data. If you want to do research, go to Denmark. They've got like incredible stuff to look at. So that's my little thing about Denmark. I also just wanted to mention, I think there are lots of folks who would love to be primary care providers and family physicians. I think that we have issues with who and how we recruit to primary care, probably more so in the family physician side. I'm being a little controversial. I am in a family medicine department. I would like to keep my job. I am a full professor. But I do think there is a lot of people who would love to work in a helping profession, that there's prestige in being a doctor, there's better pay, there's a lot of great things. It's an honorable profession, but I think we need to be looking at how we recruit and who we recruit so that we're getting people who really want to work in this way that is supporting equitable care for the population. And as you will see in my presentation, stick around for this afternoon, I'll talk to you about some of the things that physicians told us about why they're challenged in providing equitable care. Thank you.
Thank you. And I'm being told that we need to move to the next panel. So thank you so much, Andrew and Rick, for jumping in and pivoting.
Sorry, I just want to take 30 seconds to correct. I hate to correct Jane Philpott. I would never really stick my neck out ever to do that. The next panel will come up while I'm talking. But Jane said that family health teams were not associated with lower emergency department visits, and they are associated with lower emergency department visits. That was more recent research led by Tara, who's speaking this afternoon. Family health teams in Ontario are also associated with much greater satisfaction, with not only with lower emergency department visits, better chronic disease management, especially we measured diabetes care, and really great cancer screening. So, and community health centers also really fantastic. So there's a huge amount of evidence about team-based care. And it could be that in Ontario, it was a matter of maturity and a matter of time before we saw the impacts happen. But team-based care is definitely associated with better care. So
Rick warned me that he'd be hard to moderate. So I'm gonna kick him off the mic.
I'm leaving now.
Thanks again.